Astrocytoma tumors. The brain is made up by many different cells, including neurons, which constitute the electrical circuitry responsible for brain functions, and astrocytes, which provide the structure and support for neurons to work properly. Astrocytomas are tumors which originate from astrocytes, and in adult individuals, they are the most common brain tumors. Males are slightly more affected than females with a ratio of 1 is to 3. Tumor grading and its meaning. Grade 1, Pilocytic astrocytoma. It is a well circumcised tumor that grows slowly, most common in the cerebellum, that is, the part of the brain located in the back of the head just above the neck. It does not invade into the surrounding brain, thus, when resected completely, it is considered cured and it does not require either chemotherapy or radiotherapy. Pleomorphic xantoastrocytoma most frequently originates in the temporal lobes and is commonly associated with seizures. Its cells can have many different shapes but usually do not show evidence of proliferation. Surgery is usually curative. Subependymal giant cell astrocytoma. It is the most common in younger population, usually in association with familial syndrome called tuberous sclerosis. It characteristically grows inside ventricles, which are fluid-filled spaces deep into the brain, and can often block the normal outflow of this fluid, thus causing hydrocephalus. Surgical resection is usually curative. Grade 2. Diffuse astrocytoma is an invasive tumor, so there is no clear separation from the surrounding brain, and the surgery itself might not be enough for its cure. The tissue appearance is only moderately different from a normal brain, but cells appear abnormal under the microscope and slightly increase in number. Grade 3. Anaplastic astrocytoma is considered a more malignant evolution of a previously lower grade astrocytoma, which has acquired more aggressive features, including a higher pace of growth and more invasion into the brain. Histologically, it displays a higher degree of cellular abnormalities and evidence of cell proliferation. In comparison to grade 2 tumors, surgery is never considered curative for these tumors and needs to be followed by radiation almost and almost always chemotherapy. Grade 4. Glioblastoma is the most malignant, aggressive, and common form of astrocytomas. Histologically, it is characterized by very abnormal appearing cells, proliferation, areas of dead tissue, and formation of new vessels. GBM can present either as a malignant progression from a previously existing lower grade astrocytoma or originate directly as a grade 4 tumor. The former scenario is most common in younger patients, while the latter is most common in after age 60. Regardless of its presentation, this tumor is a highly aggressive cancer with pronounced brain invasion and destruction and very fast progression. Important biological features. Over the past 15 years, there have been important strides in understanding this disease, mainly derived from significant advances in the ability to study the genetic and biological underpinnings. IDH1 mutation. IDH1 mutation is a fundamental feature that characterizes a subgroup of astrocytomas with mutation of a gene called isocitrase dehydrogenase 1 IDH1. This gene is involved in providing energy to the cells. Its mutation results in production of a chemical called 2-HG, which over time builds up inside the normal astrocytes and set them astray, causing astrocytomas. MGMT silencing has to do with the methylguanine DNA methyltransferase (MGMT) enzyme involved in repairing DNA after it has been damaged by chemotherapies, thus protects the tumor against the action of these drugs. Certain astrocytomas have these enzymes turned off, and as a result, they respond significantly better to chemotherapy with TMZ. Immunologic escape means that tumors escape the patrolling immune system, which normally destroys anything that is recognized as abnormal. Astrocytomas are among the tumors which most develop the ability to escape the surveillance. They do this by activating multiple genes that can turn the immune system off. There is consensus that counteracting this immune escape will result in important therapeutic benefits. Risk factors. Astrocytomas are, for the vast majority, sporadic tumors, meaning that they happen by chance, or at least it is not known why these tumors occur. There are only two situations with proven evidence to cause the tumor. One is hereditary syndromes, that is caused by inherited DNA mutations. Second is environmental. It includes ionizing radiations. Exposure to ionizing radiations has been associated to delayed onset of astrocytomas. Warfare chemicals. There is yet unproven suspicion that exposure to Agent Orange during the Vietnam War might be responsible for delayed onset of astrocytomas in veterans. Cellular phones. Despite some suspicions, particularly related to heavy use, there is no data supporting a causative risk for astrocytomas. Symptoms. The clinical presentation of astrocytomas depends much more on their location within the brain rather than their biological characteristics. There are regions for the brain that can accommodate very large tumors before they become symptomatic, while there are other locations where even a small tumor can cause problems early on, like a limb weakness or difficulty with speech or vision. Generally, low-grade astrocytomas tend to be of bigger size before they become symptomatic as compared to more aggressive, higher-grade astrocytomas. This is because lower-grade tumors tend to displace the brain rather than destroying it, and also because they are associated with less brain swelling than malignant ones. Common symptoms of astrocytomas are the following: persistent headaches, headaches which are worse in the morning, double or blurred vision, speech problems, decreased cognitive abilities, grasp of limb weakness, new seizures.